Hello students, welcome to the session where we are going to discuss about the diagnosis, differential diagnosis and treatment of viral anterior uveitis. So, what are the clues, the clinical signs or symptoms that should alert you to a viral etiology in anterior uveitis? So, any patient who is presenting with unilateral, recurrent or chronic inflammation, you should think about a possible viral etiology. Like I said in the last session, it's also important to inquire for the history of herpes zoster. Also look for signs of a previous herpes zoster infection in the form of scars on the forehead or even in the scalp. On examination of these patients, if you see old or concurrent corneal involvement, you should think of a possible viral etiology. Similarly, the presence of granulomatous keratic precipitate or a diffuse stellate keratic precipitate, you should think of viral anterior uveitis. Viral anterior uveitis is also usually associated with a raised intraocular pressure at presentation, unlike the other types of anterior uveitis where the IOP will be reduced, and this is because of the concomitant trabeculitis. Also, look very carefully in the undilated pupil for either a diffuse or sectoral iris atrophy. Coming to the differential diagnosis of viral anterior uveitis, let's go through this table, which lays down the important clinical feature of anterior uveitis caused by the four most common viruses, namely herpes simplex, herpes zoster, cytomegalovirus, and rubella. Now, coming to the age of the patient, the varicella zoster virus, as well as the CMV-associated Fuchs uveitis tend to happen in older age group, and the rest of it happens in the young to the middle-aged. Generally, men are affected as commonly as women, except for the cytomegalovirus-related anterior uveitis, which tends to occur more in men. Now, this disease can be seen in any part of the world, but the cytomegalovirus-associated chronic uveitis is more in the Western world, as is rubella-associated Fuchs uveitis, whereas the cytomegalovirus-associated Fuchs uveitis happens more in the Asian population. Now, all of them tend to be unilateral. The herpes simplex and the herpes zoster tend to have an acute or recurrent course, whereas the cytomegalovirus and the rubella virus tend to produce more of a chronic inflammation. If you look at the signs of uveitis, I told that herpes simplex and zoster, they tend to be more symptomatic. So they tend to produce more of redness or congestion, whereas the cytomegalovirus and rubella, the eye will be white. They will have minimum signs. The keratic precipitates, they tend to be small to medium in herpes simplex and zoster. They tend to be medium to large in Forster-Schlossman syndrome. And they are stellate in Fuchs uveitis syndrome. If you look at the distribution of the keratic precipitates, they are central or paracentral in herpes simplex, zoster, and Forster-Schlossman syndrome. You get diffuse distribution of keratic precipitates in Fuchs uveitis syndrome, whether it's related to CMV or rubella. And you typically get the coin-like lesions in cytomegalovirus anterior uveitis. The color of the keratic precipitate may be white and pigmented in herpes simplex and zoster. They're generally white or grey in cytomegalovirus, and in rubella, it is white and never pigmented. Coming to the corneal changes, both herpes simplex and zoster can produce a decrease in corneal sensation, so they're very commonly associated with a corneal involvement, unlike the cytomegalovirus and the rubella anterior uveitis. So not only that, epithelial involvement will be seen only in herpes simplex or zoster in the form of dendrites or pseudodendrites. You won't get epithelial involvement in cytomegalovirus or rubella. The stromal keratitis can be seen in simplex and zoster. Cytomegalovirus sometimes can produce a immune read. Endothelitis can be seen in herpes simplex, zoster, as well as cytomegalovirus. Coming to the iris changes, it tends to be sectoral in herpes simplex and zoster, and you get diffuse atrophy in Fuchs-related uveitis. The heterochromia is usually seen in rubella-associated Fuchs uveitis. It's absent in herpes simplex and zoster. The posterior synechiae, because of the severe inflammation, is present in herpes simplex and zoster, and it's absent in cytomegalovirus and rubella-associated anterior uveitis. Again, vitritis may be seen in simplex, zoster, as well as rubella-associated anterior uveitis. Now, in most cases, you should be able to make a diagnosis of viral anterior uveitis using a combination of history and clinical examination. But sometimes you want a confirmation of the diagnosis, or it may be that the patient is not responding adequately to your first line of management, and you want to know which virus exactly is causing the problem. So you can take a Quest tab and send it for either PCR or look for antibodies in Goldman-Whitmer coefficient. There's a new technique called metagenomic deep sequencing, where you don't have to know which virus is involved. You can just test the sample and we'll give you the reports of all the organisms that are possibly involved in that sample. So the two things you need to keep in mind while you're ordering for a Quest humor sampling or AC tab is that it's better to take a sample before you start treatment, and it's better to take a sample when there is an intraocular pressure spike, but the tab itself needs to be done after controlling the pressure. So let's look at a video showing the technique of doing an anterior chamber tab. So the anterior chamber tab is normally done under sterile conditions in the operating theatre. You have to anesthetize the eye properly with proparacaine, as you can see here. And then the eye is cleaned and draped. The tab is done using a 1cc syringe with a 27 or 26 gauge needle. And remember to have the calibration of the syringe turned towards you so that you can see how much fluid you're removing. Important point is that the bevel of the needle should be turned anteriorly towards the cornea. And when you insert the needle into the anterior chamber, always stay over the iris. And now you can see the video. You can see how the bevel is turned towards the cornea, and the surgeon stays over the iris and not over the pupil. So you aspirate about 100 to 200 microliters of the aqueous and then patch the eye. So the sample which has been taken by AC tab can be sent for either PCR testing or Goldman-Whitmer coefficient testing. And let's compare the two. The PCR actually looks for DNA, and the Goldman-Whitmer coefficient looks for local antibody. This means that PCR will be positive early in the infection, whereas it takes a couple of weeks for the antibody to be produced. Also, the specificity is more in case of PCR, And in an immunocompromised patient, the PCR is more sensitive because these patients do not produce antibodies very readily. If you want to monitor the response to treatment, again, a real-time PCR is more useful as compared to looking for antibodies. Coming to herpes zoster-related anterior uveitis, treating herpes zoster itself adequately is an important step in preventing anterior uveitis. The treatment has to be started within 72 hours of onset of the vesicular eruption. The commonly used drugs are acyclovir, valacyclovir, and famciclovir. Acyclovir is given 800 milligram 5 times a day. Valacyclovir 1 gram 3 times a day, usually for a duration of 10 days. Moving on to the treatment of anterior uveitis related to herpes zoster, a local therapy like acyclovir ointment doesn't have much role. The main stay of treatment is oral antivirals. And the recommended dose and duration of antiviral therapy is with acyclovir, you have to give the full dose for roughly 4 weeks. So acyclovir 800 milligram 5 times a day for 4 weeks, or valacyclovir, which has excellent bioavailability, you can give 1000 milligram 3 times a day for 4 weeks. So along with the oral antivirals, you have to give them topical steroids to control the concomitant inflammation. The frequency of the steroids will depend on how severe the inflammation is, and you have to do a slow taper, which is tailored to the individual. Cycloplegic should be added in the initial part of the treatment to control the pain. Now moving on to recurrent anterior uveitis caused by herpes zoster. Coming to the maintenance and prophylaxis for herpes zoster anterior uveitis, maintenance is usually 400 milligram 2 times a day for 3 months, or valacyclovir 500 milligrams 2 times a day for 3 months. In recurrent cases, you have to give at least minimum 1 year of maintenance therapy. Moving on to the herpes simplex associated anterior uveitis, you use about half the dose which is used for herpes zoster, namely acyclovir 400 milligrams 5 times a day, or valacyclovir 500 milligrams 3 times a day for 3 to 4 weeks, along with topical steroids and topical cycloplegics. The maintenance and prophylaxis is very similar to that used for herpes zoster, namely 400 milligrams 2 times a day for 3 months, or valacyclovir 500 milligrams 2 times a day for 3 months. And in recurrent cases, this dose has to be held for at least 1 year. Coming to the cytomegalovirus associated anterior uveitis, the medicines which are available for treatment include ganciclovir, which you can give as intravenous, topical, or intravitreal. The valganciclovir, which is available in the oral form, and foscarnet, which can be given intravenously. And the most commonly used medicines in CMV anterior uveitis is oral valganciclovir, ganciclovir gel or drops, and intravitreal ganciclovir. So you have an induction dose and a maintenance dose. For valganciclovir tablet, the induction dose is 900 milligram BD, which you give for 6 weeks, and then 900 milligrams OD for another 6 weeks. The indications for using valganciclovir tablet is any patient who has had a recurrent or chronic CMV anterior uveitis or endothelitis, or the patient is immunocompromised, or the patient has used topical steroids for a long time, it's better to put them on oral valganciclovir. In the first episode of CMV anterior uveitis, you can try topical therapy either in the form of 0.15% gel or a 2% drops. The dose for the gel is 5 times a day for induction, and for maintenance is 1 to 4 times a day. For the drops, it is 2 hourly for 1 month, and then 3 hourly for maintenance. The intravitreal ganciclovir is given as 2 milligram per 0.1 ml. It has to be given weekly for 3 months. Lastly, we come to the rubella-induced anterior uveitis, which doesn't have any specific antiviral therapy. You have to manage these cases with topical NSAID drops, and if there's glaucoma, you have to give the anti-glaucoma medication. With that, we come to the end of the session on viral anterior uveitis. In this session, we have covered the differential diagnosis and management of different viral anterior uveitis, namely herpes simplex, zoster, and cytomegalovirus uveitis. I hope you have found this session useful. Thank you.